will get started. So welcome everyone, and thank you so much for joining us for the Dystonia Medical Research Foundation Canada presentation of the My Dystonia&I webinar series. My name is Stephanie Ince, and I'm very excited to introduce this series in partnership with Merz Therapeutics. The My Dystonia&I webinar series will focus on empowering patients and optimizing patient treatment outcomes. I'm joined by my colleague, Archana Castellino, who is our newly appointed National Director. Archana and I are thrilled to have you with us today. Next slide, please. So the My Dystonia&I webinar series offers 5 webinars during the course of September, all in celebration of Dystonia Awareness Month. Each webinar will focus on a specific area of dystonia and will feature a physician from the field. 5 separate movement disorder specialists from all over the country will be participating. Today, we're presenting our 3rd webinar in the series, Treating Dystonia, What I Have Learned So Far, with Dr. Alfonso Fasano. Next slide, please. So before we get started, I'll give you a brief introduction to Dr. Fasano. He graduated from the Catholic School University of Rome, Italy in 2002 and became a neurologist in 2007. In 2013, he joined the Movement Disorder Center at Toronto Western Hospital, where he is the co-director of the surgical program for movement disorders. Dr. Fasano's main areas of interest are the treatment of movement disorders with advanced technology, pathophysiology, and treatment of tremor and gait disorders. He has authored more than 300 scientific papers and book chapters. He is also the principal investigator of several clinical trials, including one that is being funded by DMRF Canada. Next slide, please. So just a little housekeeping before we get started. First, a very important reminder that this is a webinar presentation that aims to provide patients and caregivers with tips and tools for how to live your best life with dystonia, but we urge you to speak with your medical doctor or neurologist for a full and complete examination and to remember that you are in control of your own health. A reminder that a recording of this presentation will be made available and emailed to all of you once we have it posted online. As well, we did take some questions when you signed up to register for the webinar, and we have shared these with Dr. Fasano to help him with the development of this presentation. However, if you have additional questions as Dr. Fasano is walking you through the presentation, please feel free to type them into the Q&A chat box, and we will be moderating and bringing those to Dr. Fasano's attention after his presentation. Just also a reminder that you can use the chat function to say hi to everybody who's joining us, but to keep your questions limited to the Q&A box. So without further ado, I will turn things over to Dr. Fasano.
Okay, thank you. Thank you, Stephanie. Thank you, Dystonia Medical Research Foundation Canada and Merz for giving me the opportunity to talk to you today about what I learned so far in treating dystonia. We're chatting right before we started broadcasting about the many meetings we're all doing these days, the many Zoom meetings, and I should say, and I'm really honest about it, that for a doctor, having the opportunity to talk to patients is always very, very good. And actually, I'm really pleased to spend my lunchtime today with you, and I hope to keep you company during your lunch. So this is what I want to say with respect to my disclosures, and obviously have a number of conflict of interest because I've been working with many companies, including Merz, with interest in this field. But really, I don't think there is anything relevant to my presentation, because what I want to do today with you is walking you through my career, in a way, my path, so that you understand why I started to do things the way I do, and why, in general, movement disorders fields is moving towards the type of treatments that we're proposing these days. So this is the hospital where I was trained in Rome, and this is one of the first patients with dystonia that I happened to see. Is part of a family where this gene was discovered. So the DY13 locus, they could not find the gene, but they found part of the chromosome where this potential gene can be, was found basically by my supervisors, by the people that taught me about dystonia. And actually, my very first publication is in 2004, and it was about dystonia. This is my first publication, and it was actually my thesis when I graduated as a medical doctor. This is the first publication that I did as first author, which obviously was a great honor for me. And it was a very interesting patient, which I called here an experiment of nature. The reason why I'm saying that is because this patient happened to have two different problems: dystonia, but also myasthenia gravis. Myasthenia gravis is a condition that in a way is the opposite of dystonia. It's a disease that causes weakness. So anytime we will improve myasthenia gravis with the proper treatment, her dystonia will get worse. And anytime her myasthenia gravis will get worse, dystonia will improve because the patient will have more weakness. And eventually we treated this patient with botulinum toxin, which is in theory contraindicated in people with myasthenia gravis, using very low dose. And interestingly, every injection lasted more than 6 months because this patient already had a pre-existing weakness caused by myasthenia gravis. Okay, I don't know why. Oops, looks like my presentation stuck. Just a sec, let me start it again. I'm sorry about this. Okay, that's never happened to me, but I guess there's always a first time. Okay. Okay. So now I'm going to tell you about another patient that I happened to see around the same time. Let me share my screen. Okay. I hope you can see it now. This is a younger patient. It's actually a child. I happened to see him the first time when he was 11, and he improved a little bit with higher doses of anticholinergic. But this is an important patient for me because this is the first DYT1 patient I've seen. DYT1 is the first gene ever discovered to cause dystonia. It causes a generalized dystonia in children. It's been reported mainly in Ashkenazi Jewish, but it can be people, but it can be seen in any population. This is how I got interested in deep brain stimulation. This is the same patient. A few years after, he worsened. But thankfully, because of deep brain stimulation of the globus pallidus, which is the particular target that we use for dystonia, he did much, much better, and he actually gained weight. He basically is running a normal life now. Then learning about generalized dystonia, I also happen to know about these patients with generalized dystonia that all of a sudden had a worsening, a dramatic worsening of dystonia that requires hospital admission. This is a rare condition, probably not so rare as we thought it was back then. It's called status dystonicus. So basically people have a progression of their dystonia from focal to segmental or multisegmental to generalized dystonia. And in some cases, as I said already, there are certain triggers that cause this worsening that is called status dystonicus. And in the past, this wasn't really well known, and actually some patients unfortunately died because back then the way these patients were managed wasn't really understood. So this is the very first time this was reported. At that time, it was called dystonic storm. This is in the 80s in New York. But then little by little more papers, including my own here, were published. And finally, we published this paper years after, where we collected the largest series of patients with status dystonicus published to this date, 68 patients. And little by little, people started to realize that this is probably something more common than we initially thought. So how do we study rare situations like the one I just presented, status dystonicus? Well, I received a number of requests when I published the paper I just said from colleagues from all over the world. This is, for instance, a colleague of ours from India that wanted to know my experience about a certain patient and want to know how I treat status dystonicus. So over time, I received a number of emails from all around the world, as I said. And at some point, I got back to all these colleagues that were interested in this topic and asked them, well, do you have any patient with status dystonicus? Why don't we collect our data and we try to understand this condition a bit better? And this is why we collected a number of cases, like I said before, the largest experience with status dystonicus, and we started to look at the triggers for this status dystonicus. Very often it's a drug change. Other times it's failure of DBS or infections. Infections very often can trigger this. In other situations, instead, it's hard to predict and to understand why there was this status dystonicus. I mentioned already medication changes of any type, either starting a new medication or stopping a new medication, but also DBS withdrawal. This is, for instance, a Parkinson's patients that develop dystonia as a status dystonicus as a complication of a battery malfunctioning. So that's another important thing to keep in mind. In collecting the experience from the literature, we also gave recommendations to physicians on how to treat status dystonicus, which is basically sedating the patient. People with status dystonicus need to be brought to the hospital. They need to be admitted, probably in the ICU. They need to be sedated because, as you know, when you sleep, dystonia goes away. So the easiest thing to do to limit the pain, the muscle problems, is to put the brain, the muscle at rest using sleeping agent, basically. And little by little, you can work on the causes for the status dystonicus. For instance, an infection, you can use antibiotics. Or if you don't find any reason for the status dystonicus, you might want to go ahead and, for instance, do deep brain stimulation. So this is the new definition that we gave more recently of status dystonicus, which is recognized these days as a movement disorder emergency. So that's something that most physicians should be familiar with. It's basically a condition that needs urgent care because it can result in patients' morbidity or even death. And this is a condition characterized by the features that basically I mentioned so far, a severe dystonia that requires admission. So this is another interesting patient that happened to see in 2005. This is another DYT1 patient, and he's a famous patient in a way because it's the first Italian patient that underwent a pallidotomy. Pallidotomy means lesioning the brain in the pallidus, so making basically a damage to the pallidus of the patient. It's a region of the brain that causes dystonia. But over the years, this patient worsened. And this is why 23 years after, this is the same patient, he received the pallidotomy, he underwent deep brain stimulation of the globus pallidus. And this is the patient in 2010, doing much better than before surgery, but still having some issues with the left leg. This is another patient that happened to see with dystonia. This man underwent GPI DBS for cervical dystonia. And back then I was trying to help him as much as I could, but in doing this many changes of the programming, I actually made him worse. Obviously it wasn't my intention, but in making him worse, his dystonia worsened to a point that unfortunately I caused the bracket, the fracture of the electrode. So this little discontinuity here on the X-ray is actually the wire that got broken up by the severe posture that the man had because of my wrong setting that I was using back then. So obviously the patient wasn't happy and it wasn't particularly happy with me. However, in the end, this mistake was beneficial to the patient because he had the electrode inserted again in a different position, slightly different than where it was initially inserted, and eventually he improved. And the message here is that in medicine, doctors do make mistakes, but some of these mistakes are actually functional to a better outcome. So how do we choose therapy in dystonia? Well, it depends if we have a treatment that is available, like an oral treatment. For instance, there are certain dystonia that are good they respond well to levodopa. It's called dopa-responsive dystonia. There are some dystonias that are caused by diseases like Wilson's disease, for which we have dedicated therapies. But for many other dystonias that we still call idiopathic, we have no other treatments other than a symptomatic treatment. And the type of treatment we decide depends on the type of dystonia that we see in front of us. If we have a focal dystonia, a very specific dystonia, for instance, affecting only the neck, the first choice is obviously botulinum neurotoxin. But the more generalized the dystonia is, the more we use medications or deep brain stimulation, even though, as you saw before, Even focal dystonia, especially when botulinum toxin or drugs is not beneficial, can be used. So this is our experience at the Western. It's something that I've been doing more recently together with Dr. Gorodetsky, who is one of my fellows at the moment. And we've been looking at people referred to us for deep brain stimulation during these 4 years. As you can see, we had 67 patients referred for dystonia. This is the type of dystonia these people had. The majority were people with generalized dystonia, and most of them had received botulinum toxin injection. 30% didn't receive any injection. And this is what happened to them. Almost 50% of them eventually received deep brain stimulation. 6% are waiting to have deep brain stimulation. And obviously with COVID, there's been also a delay. And 45%, this is an interesting, I think, figure, didn't do DBS in the end for a number of reasons. First, 20% of them were functional dystonia. Functional dystonia is managed without surgery. There are different ways to manage functional or psychogenic dystonia. A good proportion of these patients didn't want to have deep brain stimulation. They were afraid of the brain operation. Some other patients, unfortunately, could not get deep brain stimulation because they were too risky, maybe they were too old. Others weren't severe enough to justify a brain operation, and some others, 10%, did better changing type of toxin or changing the injector. So for instance, I started injecting them and they did better, or we use ultrasound or EMG. I did my PhD in Germany, and this is where I refined my knowledge of deep brain stimulation. And this is where I had the exposure to very interesting cases, including this gentleman here. This gentleman has short steps, freezing of gait. He can move his feet very well. He has also a tremor at rest. Long story short, this means that this patient looks like he has Parkinson's disease. However, this is the patient before. And what happened to this man is that he underwent deep brain stimulation. So we learned that Parkinsonism, so something similar to Parkinson's disease, can be caused by DBS used for, like in this case, cervical dystonia. The difference here is that this is completely reversible, and changing the parameter of stimulation, like we find in other cases here in this publication, we are able to improve the Parkinsonism caused by deep brain stimulation. So we managed to improve dystonia without causing any Parkinsonism. This gave me an interest in gait disorder, and dystonia can affect gait often. This is, for instance, a patient with dystonia myoclonus, and the myoclonus is affecting gait. And this is a patient followed by a former fellow of ours who is now in Iran. But with colleagues in Italy, we also explored the gait of people with cervical dystonia. People with cervical dystonia usually have no problems, but when we use sophisticated measures like gait analysis, we can see that they have some gait issues that are subclinical. And we're also more recently done some retrospective and review analysis of dystonia myoclonus cases, and we also came up with the possible guidelines of how to treat dystonia myoclonus, which is a very specific type of dystonia. In this case, medications is the first step, but also botulinum toxin can be used. And we also know that these patients improve very well with deep brain stimulation. Obviously, this is too complex for you, I guess, but what I'm trying to say here is that seeing which drugs help and which ones don't or make things worse help us understand what are the biochemical reasons for this condition. And this is what this picture is meant to show. We also started to do at the Western MRI-guided focused ultrasound. This is something that I'm sure you are familiar with. It was all over the news at some point. And what is this MRI focused ultrasound effect that I'm showing here in this table? Because we were offering this treatment, we started to have a number of referrals from everywhere in the country for this treatment. And this is, for instance, only people with tremor that were referred to us. And as you can see, in the past, we had more or less 10 patients referred to us for deep brain stimulation. And after this came up, a lot of people were referred for focused ultrasound. what this caused is that we happen to see a lot of people that also had very interesting condition, including something called dystonic tremor. So tremor caused by dystonia. This is just to show you how focused ultrasound works. The patient is awake and he goes in a special MRI machine. The neurologist assesses the patient, and right after the procedure, the patient has already an improvement. The patient has to be shaved, and during the procedure, we can actually see the MRI of the patient and make sure that we shoot ultrasound in the right spot of the brain. And this is how it looks like. We target the classic areas of the brain used for deep brain stimulation surgery, for instance, but we just do this in a different way. For instance, this is the thalamus, which is a target used in dystonia, in tremor, and the same, this is done with focused ultrasound, but the same can be done with DBS electrode, inserting the electrode, or with an old procedure called radiofrequency thalamotomy. This is one of the first patients with dystonia we operated at the Western. It's a patient with writer's cramp, and you will see the effects after 1 month of focused ultrasound. And you can also appreciate the improvement of the handwriting. And you can also see that perhaps over time there is a slight worsening. The best outcome is usually right after surgery. However, we also happen to see, and this is a patient from the UK, in other patients and also in Toronto, that when you do thalamic procedure in dystonia, sometimes you may see an improvement of the tremor, but you may unfortunately see a worsening of dystonia. This is extremely rare. We collected 6 patients in 5-6 centers over many years, so it's not common, but it's something that we definitely need to keep in mind. And eventually this patient underwent another operation in the pallidus, which is the target used for dystonia, to improve dystonia. Remember, I mentioned that we happen to see a lot of tremor cases, and in some of these tremor cases, we happen to see interesting features, like this man. This man was diagnosed with essential tremor, but on the video, you may notice that he has a posturing of the wrist, something that is similar to dystonia, and indeed he also has a writer's cramp, which is a form of focal dystonia. So this condition is these days called essential tremor plus. I won't give you too many details about it, but this is just to say that we don't really understand very well many essential tremor patients, especially when their condition resembles more dystonia. And this is why we more recently started to use smartphones to measure the tremor. This is a very busy table that you don't have to know, but this is basically to say that if we use a smartphone to analyze tremor in Parkinson's, tremor in essential tremor, and tremor in dystonic tremor, we are not able to capture any difference, even when we use a very sophisticated tool like a smartphone. We might see some differences using clinical scales. For instance, in dystonia, we see more dystonia. Obviously, in dystonic tremor, we see more dystonia measured with this scale that is meant to measure dystonia. In dystonia, more often there is asymmetry of the tremor, but clearly we are not good at detecting the difference on a clinical ground. And actually, when we use scatter plots like this, this is something called cluster analysis, we don't really differentiate these different conditions. So clearly a lot more is to be done in this context. For the sake of time, I'll skip this. And I want to say a few more things about the DBS outcome, because at the moment we base our decision whether to go ahead with deep brain stimulation or not on few features that the patient presents. And I want to say a few things about parameter of stimulation that we use, about the target that we use. You heard already about GPI, which is the main target for dystonia, about the timing for deep brain stimulation. That's important because it looks like the earlier the better. And also the genetics, according to what we call personalized medicine. So programming DBS is not easy. And it's not easy, particularly for dystonia, because in dystonia, we can use whatever parameter we want, but we don't see any improvement right away. We need to wait to see an improvement. And this is why we put together an algorithm on how to program in a standardized fashion these patients, which take time. And this is particularly challenging in Canada because we have patients coming from everywhere. So this is a paper that we published 2 years ago using remote programming. So we used telemedicine. And this is well before the COVID time. And back then we were already using telemedicine. So we were using people on TV screens, on the computer, and using the remote control, we were teaching them how to program their own DBS. And the average distance from Toronto Western, which is the little star here, was 800 kilometers. And this inspired us to do this type of analysis here. In this study, we compared people that were programmed using the remote control that they have versus people that weren't programmed using the remote control or simple mode. So these are survival tables. This is what it's called. And this tells us how many people have their DBS optimized over the months. It doesn't matter if you use an advanced mode with a remote control or the good old ways where the patients come to the hospital many times. It will take more or less the same amount of time to program patients. As you can see, in some patients, we can only finalize the programming after 1 year. This is 12 months. But what this study shown is that when we use the advanced mode, so the remote control, people get the same effect with fewer visits. So they can be seen less often, which obviously makes a lot of sense in big countries like Canada. But we are now moving forward and we're using fMRI. So fMRI is able to capture what happens in the brain of people during different settings. So this is, for instance, a Parkinson's patient with an optimized parameter. And this is the same patient when using parameters that are not good. And we also have different signature depending on other, for the other conditions that we're using, like using DBS for, like depression or Alzheimer's disease. And this is another example of a Parkinson's patient that you can see that only when we're using the right contact, we have that particular signature at the MRI. And right now we are doing the same experiment in Dystonia, thanks to generous donation of the DMRF. We've been using the grant that they gave us to do this type of experiment in Dystonia, hoping that in the future we'll be using functional MRI to program Dystonia 2. We're also using a lot of MRIs to understand where to go with the electrode. And we are now collecting data of hundreds of our cases, and we're creating heat maps of where it's best to stimulate the globus pallidus, basically the yellow spots in the brain, and where not to go, the colder color, because otherwise we make dystonia worse. So we're also learning where to go with the electrode. Timing is an issue, as I mentioned already, and it looks like that if we do things too late, when there are deformities, like in this patient where there's dystonia and scoliosis, well, operating for dystonia might improve dystonia, but it might not improve scoliosis or other bone deformities. And this is another similar story. This is another man that happened to follow with dystonia, generalized dystonia, and is not a DBS patient, and most of his disability actually comes from the cervical myelopathy, because over the years, the torticollis, the generalized dystonia, as you can see, twisted is spinal cord, and this is why now he's having these problems. This is a patient of ours that has dystonia affecting his wrist. He has a Brad's cramp, he has dystonic tremor, and he didn't improve with DBS. And when I tried to understand why DBS didn't improve, I noticed that his cerebellum was very atrophic, it was very small, and therefore we did genetic testing on him, and we figured out that he had a mutation that causes ataxia, which is another disease altogether. And ataxia patients are known not to respond well to deep brain stimulation. So where I'm getting at with this, well, that probably we'll need to use more genetic information in the future to select our candidates. And it's also important to publish people that don't do so well. This is another papers of ours where we reported many people that we operated on, unfortunately not doing very well. And that's important because we need to share knowledge so that other centers don't do necessarily the same thing. In some cases, instead, we happen to select candidates and without a clear diagnosis, but they are reaching out to us for surgery and doing analysis. Later on, we may find new genes or new expression of genes that haven't been reported to cause dystonia, perhaps. And this is a patient followed in Mexico by my colleagues that has a new variant of a mutation of this gene called ATP1A3 that is now known to cause episodic period of status dystonicus. And now you know what it is. And in this case, you don't have to have a trigger. Simply having this mutation causes the status dystonicus, and DBS in this case helped. So this is something we published this year, and again, very complicated, but these are genes that causes dystonia. We are now little by little trying to understand which genes do well, which genes don't do well, so that in the future we'll be better at selecting patients. So for instance, this woman has a gene called TAP1 mutation, or DYT6, and this woman underwent surgery twice, and neither time surgery helped. And now we know, not just because of what we've seen, but also because of what's been published by others, that this type of mutation doesn't always provide a good effect to patients when DBS is done. On the other hand of the spectrum, this is another gene recently discovered, KMT2B, which is a disease that causes dystonia in children. And it's known that this condition responds well to DBS. And actually, this patient was sent to me because of the gene that was found. This patient is doing well at this point. You see in the video. She doesn't really need DBS. However, the neurologist, the very smart neurologist that saw this patient, knew that this gene responds well to DBS. And the patient was sent to us because they wanted us to start to get familiar with this patient, because one day this patient might have needed DBS. And actually, this patient eventually underwent deep brain stimulation later on. So this is one of my favorite patients, as she knows, and she's actually, she should be on among the attendees. She knows that I was going to present her case today, because I also learned a lot from her. She has a different type of dystonia caused by cerebral palsy. And as you can tell from the video, dystonia is still present, but after a year of DBS, her dystonia improved, particularly the fast movements that she had while walking, the head movement, the shakiness of her head. These symptoms, these signs, they all improved. But she wasn't really happy because she hoped to have more improvement of her walking, for instance. And at some point, she came back to me complaining of additional problems. They are not typical dystonic symptoms. She was closing her wrist, her fingers, clenching her hands. And as you can see from this video, what I'm doing here, I'm distracting her. And when she's distracted, she doesn't have these involuntary movements. So what she's presenting here is something else that is not the initial dystonia that she had before. This is a dystonia caused by functional dystonia. So it's another type of dystonia, probably caused by the frustration that unfortunately she was experiencing because she wasn't getting as good as she wanted her to be. And so this is showing that with suggestion, the dystonia will improve. Eventually explain to her that this is not something that we can treat with additional parameter adjustment. And actually this particular movements went away. And over time, additional problems developed. And now I'm treating Julie, this is her name, Judy, this is her name. We're treating her with botulinum toxin on top of deep brain stimulation. And ask her permission to show these videos that you're going to see in a second. But this is part of an experience that we published later on, that functional disorders can arise after a successful deep brain stimulation or semi-successful deep brain stimulation. And this is the way she does today. She graduated. She's done certainly a lot of things in her life. She's finding a role in the society, also from a career standpoint, and finding a job. And I'm happy that's been, part of her journey so far. And now I make fun of her when we meet from time to time for the botulinum toxin, when I say that her major problems is the type of music she listens to, because we don't agree on the musical taste, but she wants to hear music during the botulinum toxin injection, because this way she gets relaxed. So this is something that personally makes myself very proud of what I do, because it makes sense that we're trying to help people. And you might remember this patient, the one that didn't do so well even after DBS. And this is a video that he sent me a while back after a programming session. He did much better. And this is him dancing with her partner. So again, this is tapping into the biography of patients. I think it's important to know how they do these days. This is the first patient I ever reported, and this is the way she's doing today. We're connected on Facebook, and she's doing very well. After many years, obviously, I'm not in touch with her from a medical perspective anymore, but we still got in touch from time to time. Still a lot needs to be done. This is a publication that we did a while back where we looked at what's been published and what's not being published. And clearly more is to be done, particularly for dystonia. Dystonia is this part of the graph when it comes to epidemiology. We don't know what's the real prevalence of dystonia. A lot has to be done for genetics, for instance, or also for the classification of dystonia, perhaps. So this is just to say, yes, that we've done a lot over the years, but certainly we are very far from finding a cure, as you know, we're far from finding something that is really beneficial to all patients. But I can still share the lessons I learned so far. First and foremost, something is always possible to help patients and their dystonia. There might not be a cure, but there is also something we can do to ease their conditions. Every patient teaches doctors a lesson, and clearly I showed you some of the patients I happen to see over the time of my career, and been lucky enough to meet a lot of great people, and each of them, I'm really grateful to them, each of them really taught me something. And at the same time, in being exposed to this complex condition and difficult condition that is dystonia, we are little by little understanding this condition better, and we are sharing our understanding with the community of physicians worldwide, but also with patients community. And in this context, it's really important that there's an open exchange between doctors and patients, because the more we do together, the better we move this field forward. And with this, I want to thank again Dystonia Canada for the opportunity and that they gave me today in sharing my experience. Also Merz for sponsoring this event, and also the many patients happen to see over the years, and also last but not least, many people have the pleasure to work with at the Western, the neurosurgeon, the team at the Movement Disorder Center, and particularly the many fellows from all around the world, and the residents that helped me taking care of these patients. Thank you. And last but not least, I also want to share a recent experience that we are having now, because I'm now also going to Sick Kids. This is the team of Sick Kids. George Ibrahim, for instance, is the neurosurgeon there. We are moving part of the care, the hospital for sick children, so the kids don't have to come to the Western. It is an hospital for adults, obviously. And we are now we started already a very successful DBS program there that also obviously take care of dystonia patients. And I will also want to thank them all for their kindness and for giving me the opportunity to learn from their Sick Kids. Thank you.
Thank you so much, Dr. Fasano. That was an amazing presentation, and it's so great to hear about all of the work that you're doing. And I think I can speak on behalf of the dystonia community that we appreciate all that your colleagues have been doing to advance dystonia research. And looking at the history that you presented, it definitely makes us appreciate where we are in terms of dystonia research at present. And yes, we understand there's a lot more to go, but yes, on behalf of the community, thank you for all that you're doing. And it's great to hear that you're also going to be working at Sick Kids now. So that's some great progress there. All right. We'll move into the Q&A session very soon, but before that, I'd like to highlight some of the patient tools and resources we have. I just wanted to share that because as we have, I think, quite a few people from Ontario and GTA present on the webinar today, we would just wanted to highlight the support groups that are available. We have a quite a few area contacts spread across Ontario for you to reach out to. And we have a GTA support group that conducts online meetings now in this new world. So please do feel free to visit our website and connect with the support groups. Then we also have educational materials. We have a patient survey report that we'd conducted a couple of years ago. It's very useful information on dystonia patients. Then we have a new patient-to-patient guide developed by Merz, which is a very useful tool again. It's all about patient experiences, and it's by patients for patients. So please feel free to look at that too. It's all available on our website, dystoniacanada.org/mydystonia. Also on that page, you will find our Dystonia lanyard that we have launched this year. It can be used as an awareness tool or as an aid, however you feel comfortable using it. Also, our Dystonia ambassador, Casey Kitson, she has released 3 new fitness videos on stretching, cardio, and core exercises. And finally, we also have at the beginning of the pandemic in April, we had conducted a webinar on COVID-19 and answering all the questions that dystonia patients had at the time. Please do feel free to check out all these resources on our website. Okay, and thanks, Dr. Fasano. We can move on to the next slide, I think. Okay, time for question answers. We have quite a few questions. I think you have covered most of them during your presentation. Thanks so much for that. We do have some additional questions that I have here. One was, this is about functional dystonia. We know that this is a topic in its own, and it's a large topic to cover, but a patient has asked, what is the best treatment out there for functional dystonia? And there is another question related to functional dystonia too, so I think I'll just ask them both together. How do you distinguish a functional dystonia tremor from an organic one?
Yeah, so those are very good questions, and I think over the years we haven't done a good service to the community of patients addressing functional problems as they should, because functional problems are very common. It's about 20% of the referrals to tertiary centers like ours. So any tertiary center has to deal with functional patients, and the reason is simple, because functional patients tend to be the most disabled ones, because the standard treatment that we use for non-functional cases don't work. And actually, oftentimes they're referred to us for deep brain stimulation because they say, well, we tried everything, nothing works. And then we figure out that the patient didn't respond because the diagnosis wasn't correct. It was functional dystonia. So I will address first how we diagnose and then the treatment. The diagnosis is based on a number of positive findings. In the past, there was the idea that we had to rule out any possible condition on Earth before we could say that the patient had functional dystonia. This is now wrong. We know that certain patterns are typical and specific of functional dystonia. For instance, fixed patterns. People that have shoulder elevated all the time like this, or a torticollis without movements all the time like this. This is typical of functional dystonia. An acute onset is typical of functional dystonia from one day to another. The onset during a stressful time or after a car accident is also quite common. Also after any medical intervention. For instance, a while back, there was a famous cheerleader in the States that claimed that she developed generalized dystonia after the flu vaccine shot. And so, of course, everybody was against vaccines back then, blah, blah, blah. But actually, it was a typical functional dystonia. And again, was triggered by a medical intervention. From a positive standpoint, also what we looked at during the investigations in the clinic is the distractibility. As you have seen in the video I showed, when the patient's brain is engaged in something else, dystonia changes. Because the mechanism that is sustaining the dystonic contraction is basically the same of voluntary actions. And therefore, when the patient is doing something else voluntarily, there's no dystonia or less dystonia, or the dystonia changes. So this is something we call inconsistency, meaning that the dystonia comes and goes or changes over time, or as remission for a month and then it comes back, or response right away to botulinum toxin injections. I have a couple of patients that I know they're functional, confirmed the diagnosis because their dystonia improved the minute after I injected botulinum toxin. And this is not possible because botulinum toxin takes at least a week to kick in. So that's something else that we call being incongruent with what we know in medical literature. Obviously, this is a difficult topic also because back in the days when dystonia wasn't known, I'm talking about the 70s, every patient with dystonia was considered to be psychogenic. And psychogenic dystonia is the old name used for functional dystonia. So many doctors are nervous these days when they label someone with functional dystonia because they don't want to do the same mistakes that many years ago was done when we didn't know dystonia. But I would say now we have a good knowledge of dystonia that we can easily, most of the time, diagnose what's functional, what's not. What makes things more complex, as you also saw in my presentation, is some people have both, have a non-functional dystonia and a functional dystonia. And you might notice that I'm not using the word organic dystonia. I don't like the term organic because even functional dystonia comes from the brain and therefore it's organic. It's just a different cause, just a different etiology. As for the treatment, obviously the standard treatments used for dystonia don't work. And not only they are useless, but they're also dangerous because you do something not needed that doesn't work, like a brain operation. And also people with functional symptoms are very sensitive to what's being done to them. I told you the example of the flu shot. So the paradox is that the more you do to functional patients in terms of invasive treatment, the worse they get, besides perhaps an initial improvement, which is basically placebo. So the way we treat functional dystonia is, first of all, with diagnosis. Many people, when they are told about the diagnosis, improve. We don't understand why. Some do, some others don't, but simply being aware of that this is a possibility helps. The other way we help these patients is avoiding this medical shopping. They go from one doctor to another, from one doctor to another, and sure enough, they also meet people that charge them a lot of money for whatever miraculous treatment that never works in the end. So that's another way to protect them from being excessively medicalized. That's the term we use. What seems to work fairly well for functional dystonia is rehabilitation, physiotherapy of certain types, but also meditation, yoga, any type of exercise that ease up the muscle attention and at the same time beneficial to the well-being of the person helps. We call this functional dystonia no longer psychogenic dystonia because we recognize that not all the people with functional symptoms have depression, anxiety, post-traumatic stress disorders. In other words, people might have functional dystonia without any psychiatric problem. That's why we don't call it psychogenic anymore. But in case we have a functional patient with psychiatric problems, and those are quite common, obviously, those need to be treated because it's known that if you treat them, the functional dystonia part will improve as well.
Oh, that
so
explains.
That's an
Yeah.
answer.
That was a great answer. That explains and that answers a lot of questions. We've got a couple of them in the past, and I'm sure patients with these questions will definitely appreciate your response to this one. Okay, next I have is, so patients said that they had cervical dystonia and had DBS, but when the DBS is activated, they mimic Parkinson's disease, which you mentioned in your presentation. And they were wondering if that response can be successfully treated with maybe exercise or any other methods.
Yeah, the first thing to do is to change the settings. As I mentioned before, there are settings of stimulation that are in theory meant to improve dystonia without causing Parkinsonism. So it's important to try those things first. If there is no way to find a compromise, then it's important to obviously find the best possible option and then work on what's left. If there's Parkinson's left, it's known that medications for Parkinson's don't work. In this case, it's been tried and they don't work. Physiotherapy certainly helps. But before going there, I will do any possible adjustments of DBS to avoid Parkinsonism, which may include moving to a more dorsal contact and using low frequency of stimulation or less strength of stimulation.
Okay, so I guess they will have to talk to their doctor, of course.
Yeah, of course.
With all of this. Okay, next I have is, what is the global level research focusing on today in terms of research on dystonia?
Yeah, no, a lot is happening, but not as much as it should, because dystonia is a rare condition, certainly rarer than hypertension, diabetes, Parkinson's. And the downside of a rare condition is that the funding that is out there is not the greatest. It's not that you have millions of dollars to use or philanthropy to use. And this is a problem. And this is why it's important there are foundations, like, of course, the DMRF, they're really meant to fill this gap. So yes, there is research going on, and this research is mainly focusing on genetics. Why genetics? Because from genes, we understand what's lacking, what's not working in the brain. And that will be the first step towards a personalized treatment, or hopefully a cure. Because once you know what's wrong in the brain, you can perhaps replace that protein or that gene that's not working.
That's great. Yeah, finding the cause of it to tackle the problem. Yeah. So a couple of patients have asked this. They've asked about pain management in treatment of dystonia. And one particular patient has mentioned about their child having dystonia, is 5 years old. So maybe if you can talk about how can pain be managed in the treatment of dystonia?
Yeah, that's a very important question, because pain is a determinant of quality of life. It's well known that dystonia is affected particularly when there's pain. And I would say there are different types of pain. If the pain comes from muscle spasm, clearly dystonia has to be better managed. If dystonia, well, botulinum toxin should help. Actually, botulinum toxin works better for pain than for postures. And this is the reason why you might wonder why botulinum toxin is used these days for migraine, for headache. The reason is because at some point people started to realize that patients respond even more when it comes to pain than postures. So dystonia should work for muscle spasm. Medication for dystonia should work for muscle spasm. Pain management per se is probably not the best thing to do, because if the patient has pain, means that dystonia needs to be better managed, even doing DBS, for instance. Also in kids, sometimes we use high doses of drugs that only cause sedation. Yes, you have no pain, but the kid is sedated, has issues at school to learn, or is floppy. Pain indicates that more is to be done, even DBS if needed. The other type of pain that is important to recognize is pain caused by musculoskeletal problem. Because if I have my neck twisted for 10 years and then I have neck pain, that neck pain is not caused by the muscle pulling. It's not dystonia anymore. It's probably the spine that is showing arthritis, perhaps. And so this is once again emphasizing the need for early intervention. Because if we wait too long, then you're going to have pain for the rest of your life, and you don't want that.
Yeah, thanks for that. Yes, early intervention was was one of the things I got from your presentation. Sorry, I have a patient asks if what is the difference between, if any, between gamma and ultrasound?
Yeah, that's another good question. I've noticed. Peter is probably talking about gamma knife and focused ultrasound. Gamma knife is a non-invasive way to lesion the brain. So both ultrasound and gamma knife basically cook the brain. So lesion destroys certain part of the brain. Gamma knife does so from far, shooting radiation. So those are X-rays, basically gamma rays, I should say. And ultrasound instead uses ultrasound, which is like microwave kind of thing. There are two important distinctions apart from the actual physical particle that is shot. Gamma knife uses radiation, and therefore you might expect over the years perhaps additional problems that we don't know yet, because radiations, in medicine, we're always a little nervous when we use it. The other major difference is that gamma knife doesn't make a lesion, a brain lesion right away. You need to wait for the radiation to kick in. So while ultrasound has an effect right away, and perhaps that effect decays over the years, gamma knife, you need to wait 3-6 months sometimes before you see the effect, because the radiation needs to slowly kick in. And the downside of this is that perhaps sometimes the lesion keeps on growing, and that's something that makes us a little nervous. But gamma knife has a big advantage, which is the fact that it can be done in people on blood thinners. So people with anticoagulants or blood thinners of any type, they need to stop these drugs before any brain surgery. The only exception to that is gamma knife, because gamma knife kicks in slowly. So people that might not be able to stop the blood thinners are good candidates for gamma knife.
Okay, thank you. Just gonna look at some other questions. There's a patient who has asked, have you seen a patient with spasmodic dystonia go into remission?
Yeah, it's possible. It's being reported. Is there another part of the question? Sorry, I cut you off.
Yes. And is it likely that the remission will last?
Yeah, so I was going to say this is not a well-known phenomenon, but it's being reported rarely. So we typically don't tell patients because we don't want to give a false hope. And the other unspoken part to this is that this was reported mainly in the past, and I suspect that this happened mainly in people with functional dystonia back in the days. And we know that functional dystonia can improve forever in theory. So I will not say it's impossible in dystonia, but it's rare. If it happens, I will question maybe it's a functional dystonia, but I'm not saying that all people with remission have functional dystonia. It's in theory possible with dystonia, because dystonia is a very interesting and difficult condition. So in theory it can happen. And I would say if it happens, for the same unknowns that I mentioned so far, it's hard to predict whether it's going to come back or not. For instance, back in the days, I described dystonia only during pregnancy. And this patient will have dystonia anytime she got pregnant. And then the dystonia will go away. So certainly there's a lot that we don't understand yet. So it's very difficult to give an answer that is based on evidence. That's why I'm afraid I don't have a full answer to this question.
Thank you. That's good enough, though. I think that covers what we know about it at present. I think that's about it. That's how much time we have. We're almost 1:30 now. So I would just like to thank everybody for joining in, and thank you so much, Dr. Fasano, for answering all these questions. I'm sure patients have appreciated all that you are doing and all that you've addressed during this presentation. Just a note to everyone that DMRF Canada is not recommending any specific course of treatment, and any new or experimental treatment mentioned here today may still be relatively new or exploratory at this time. So a reminder, please speak with your movement disorder specialist about any course of treatment to ensure it is right for you. So I also want to take a moment to thank Merz Therapeutics for their very generous support of the mydystonia&I webinar series. As you know, as it is taking place until the end of September, we have 2 more webinars to go next week. So if you haven't signed up already, please do sign up. Recordings of all these webinars will be available in October. Please do check out our website. And once again, thank you so much. We really, really appreciate your help and taking the time out to do this webinar with us today. Right.
Thank you all. Thanks for having me.